Thank you, Dr. Lingam Gopal, for including me in this course. I'm going to talk to you a little bit on the laser treatment. I think we all are aware that laser became popular after this ETROP study and became a standard of care. And we also know about the indication. I'm not going to go into that. We have more number of babies for laser treatment than in the threshold era, and that you can see from here. We, from olden time, we never used to treat these stage 2 plus disease until unless they reached what they call threshold disease. So, and aggressive posterior ROP, this I would like to mention. Perhaps many of us, those who are in this working on ROP for a long time, in our country, anywhere, I think 40 to 50%, half, or maybe these days more, they are APROP because I think they are more of what we talked, oxygen-induced retinopathy. The way we do laser treatment is concurrent laser. At least we believed in our center right from beginning that if we are not doing a concurrent laser, then it is not going to work. I think that is something which has been established now. With this kind of a laser, you will have 90% favorable outcome, as well as plus disease would show regression first. That is something which you should. Now, I think before I go even to this, I would like to ask you, how many of you, what kind of laser you use? You use green laser or 532 laser? Here in the panel as well as in the hall. Diode laser, how many? And green laser? So, okay, yellow, okay, all right. So we have mostly using green laser. And I'll also like to ask you, how many of you do laser posterior to the ridge? Okay, not as a routine. Yes, I think that's important. I think if you have, I think we saw a very nice picture from Irene. She had shown in many of those angiograms that the retina behind the ridge is avascular. She showed very nicely in those pictures. I think so there is a even further rationale, I thought, while sitting here to do laser behind. And it does work. Like in this particular case here, it worked for us. Very aggressive disease, posterior disease, and you will have a very good regression because I think you are also treating avascular retina here. And of course, I would have asked this question here. I think we feel very good about this publication long time back when Anand was still with us. And when first we presented in American Academy as a poster and then subsequently in British Journal. You see, it was before that one report only where they had excluded everything with TVL, with other things. So that is everywhere we have seen. So what we observed, even if you have a TVL, you have a vitreous hemorrhage, no cataract, you don't see, and the effect would come the same way. And that's what the experience is, more and more people. Otherwise, in the beginning, we had to procure that diode laser exclusively for ROP, which is not a feasible option in our country. Obviously, I think green laser burns look a little different, but they work very well like this one. And that is the way you will have a very good regression. And in some unstable baby, you can do inside the incubator. I think Anand has already shown this. And this also happened accidentally to us. It is possible to do through the sloping walls. And I think Anand is there. This way back, probably we did maybe 2005 or 6 somewhere this was taken. And this is very important. Sometimes they would not allow you to bring out, or sometimes the baby gets very sick right in the beginning when you start laser. So you can always subsequently come and do that inside. And with the same parameter, you rotate around and it will be fine. The problem is aggressive posterior ROP. Now, in this particular report, which we published first of all, way back in Retina 2009, we had something like 71% success. I wanted to mention here today, we have recently got it is coming as a publication in the Canadian Journal. In posterior zone 1 or zone half, we had 80% unfavorable outcome with laser. 80% unfavorable, despite doing very good laser. So that is where the same question comes back. So how many of you see posterior zone 1 or zone half ROP. So it's not uncommon. It's not uncommon. So we have a challenge here. I think that is where we have a big problem, and we need to somehow look into that aspect much more closely. And we did look at, because we started focusing on APROP from our center, because we were seeing so many of such cases, that which are the cases going into unfavorable outcome and ultimately going into retinal detachment. So this in American Journal in 2013, we reported the posterior zone 1 ROP. That is where I was. And if you have a pre-existing or a new onset fibrophospholipid, if there is a pre-existing, and if it is all around, whatever you may do, it is going to contract. That is where we have realized today, and many of us, those who are doing surgery, that if we don't go in early, it just contracts there over the optic disc. That's a problem. If it is still limited, maybe what in olden times, there was some publication where it was mentioned that if you have less than 4 clock hours of proliferation, you can still wait and watch. So I think there is some merit in that still. So, so we have a lot of difficulties if you have something tunica vasculosa lentis like that. And sometimes the pupil doesn't dilate at all. It will remain very small. You can hardly see in. The disease is very severe, very posterior. And you sometimes have a proliferation like that, or if you have a hemorrhage, or you have so many things happening. So in such a situation, I think that is where we need combined treatment. And it's also a problem. Sometimes we can't even do a combined treatment. Now, how many of you, I'm asking you, would inject anti-VEGF for this particular eye? How many of you? So none. That is where the problem is. Now, how do you manage this? We did laser to the best of our capabilities, and just in 2 weeks it became like this. Anyway, lucky for this particular child, went in, did lens sparing vitrectomy, and ultimately just looking at these vessels, even at this stage, would you like to go in and give anti-VEGF? So again, the problem. So we face all these challenges. But you see, you just remove this, remove as much as vitreous possible, don't touch, don't go near this. If this is going to bleed, then we have lost everything. I think they contract. I think there's so much of blood inside that finishes everything. Otherwise, this had a favorable outcome. So we need combination treatment for ROP, especially posterior zone 1. I already talked. We had 80% absolutely unfavorable outcome. Severe tunica vasculosa lentis. Sometimes the pupil doesn't budge. You have vessels all over. And of course, if you have inadequate laser treatment due to hazy media or hemorrhage, sometimes best of your capability, you can't do complete laser, or you can only do half the laser. Or sometimes you have progression despite laser or anti-VEGF treatment. I have not purposely brought here, which would have led to long discussion. I'll just ask that question to you. When do you do laser after anti-VEGF treatment? Do you do laser after anti-VEGF treatment? Let's, how many of you do? So quite a few would do that. So would you, what time would you prefer to do laser after anti-VEGF treatment? 1 week? Any? 2 weeks?
2 weeks.
Okay, all right. Anyway, after anti-VEGF. So
I would only moderate the statement by saying, what was the purpose of doing the laser? In other words, you want to sort of get a more permanent result quickly without worrying about persistent avascular retina in the periphery, right? But at the same situation, you're giving anti-VEGF to start with because you don't want to destroy too much of the posterior retina. So I would wait till the vascularization spreads to a point beyond which I don't mind destroying the retina, rather than treating 1 week or 2 weeks after anti-VEGF. So I will give anti-VEGF and wait for the revascularization to take place, if it takes place. And if I'm lucky and if it comes up to say equatorial level, then I will do the laser. I won't worry about what time I'm doing. as it is anyway, you are going to follow up every week. So we see every week and then take a call as to when I would like to add laser. Because just giving anti-VEGF, what you achieve is immediately, of course, plus disease is gone. But that is not the end point we are looking at. We are looking at a revascularization as well.
Pramod, you have something? Yeah.
There are two things, like one phase, not exactly what the picture you have shown. There is a situation you get a very, very fleshy thing around the vessels. The vessels are truncated at zone 1 or maybe just approaching zone 2 and very, very fleshy thing around. Probably this is a scenario. Again, you need an aggressive treatment. Probably this is, I won't wait. What I do is I give anti-VEGF because pupil doesn't dilate. A lot of other issues are there. So I inject, wait for a couple of days, and I take this opportunity to blast rest of the retina, because there is no question of waiting these eyes like 3 weeks, 4 weeks. These are just going to prop up. And here again, probably additional side effect of anti-VEGF, we take a call that it may like a pull-up fibrosis. But yes, it works quite some time. That the fleshy thing disappears, things work out, but this is not a time waiting for 2-3 weeks.
Yeah.
The second group where we are talking classically, you do a laser, give anti-VEGF, have a sequential follow-up, and the first sign, because now you have after anti-VEGF, these vessels are regressed, diameters are gone down, vessels are sort of straightened up. But the first sign where you feel like vessels start becoming tortuous again, start dilating again, that's something happen anytime after 2 weeks, generally somewhere between 3 or 4 weeks. But the advantage of waiting till that time is what Dr. LG said, is you are already usually reached by anterior zone 2. And then you destroy rest of the retina. Most of the time I won't give second anti-VEGF injection. And that area, that is the time I blast with laser.
Pramod, it
Absolutely.
would also depend on what kind of anti-VEGF you have given, because these things come up more easily with
I think we have a
ranibizumab
talk
than with
also on
bevacizumab.
anti-VEGF, so I think that rest we can discuss there. I'll only say that we have to kind of what Gopal said, I have to emphasize, we also wait. If it is nothing is happening, we are not doing for everybody. But what Pramod also said, especially you have a nasal raised, I think we are very afraid. Already fleshy thing what you said, I think there we go in with laser very early. Thank you.